Good morning, everyone. Welcome to the Buncke Clinic Virtual Visiting Professor series. On behalf of all of my partners here at the Buncke Clinic, I have the distinct pleasure of welcoming a dear friend of the clinics, Dr. Theddeus Teddy Prasetyono from Jakarta, India. Dr. Prasetyono is a consultant in hand and microsurgery at the Cipto Mangunkusumo Hospital in Indonesia. He's also the chairman of the Indonesian Clinical Training and Education Center. I've tried to summarize Dr. Prasetyono's accomplishments in a couple of slides. It was difficult to do, but I tried to compress it quite a bit. So he completed his general surgery and plastic surgery at the Universitas in Indonesia. And then he was a PSEF fellow, so quite a prestigious accomplishment. And he spent time at both the MD Anderson Cancer Center in Houston, as well as here with us at the Buncke Clinic in the early 2000s. His clinical interest is in non-tourniquet techniques of hand surgery, and we had Dr. Don Lalonde give us a talk last week about that, and so we'll hear a lot more about that today. As his other interests include free flap surgery, vascular anomalies, aesthetic surgery, as well as training and education. Dr. Prasetyono has been visiting professor or visiting surgeon at many prestigious places around the world, including Asan Medical Center, the Kaohsiung Center in Taiwan, Suncheonyang University in South Korea, Philippine General Hospital, Grigori Papa University in Romania, Sapporo Medical University, as well as the Kuala Lumpur Hospital in Malaysia. He's authored 23 books and chapters. He's also an editor and reviewer for the Archives of Plastic Surgery and Archives of Craniofacial Surgery, as well as the Journal of Surgical Research. He has a certified patent from the Indonesian government, as well as 14 certified copyrights by the Indonesian government. He's very involved in many international societies. He is the Asian Pacific representative of the Board of Representatives of IPRAS. He's also the president of the Oriental Society of Aesthetic Plastic Surgery. Teddy, with that, thank you so much for being with us. It's really an honor and a pleasure to have you with us, and we're really looking forward to your talk today.
Thank you very much, Boba.
And looks like we're getting some background noise. I'm going to ask everyone to please mute your microphones so that we don't have any disruptions or interruptions during our talk. Thank you so much. I think I'm still, Teddy, let me make sure before you start, I can find out who it is, whose mic is. There we go. It's this person.
Yes, please.
I think we're good now. Okay. Go ahead.
Thank you very much, Boba. Thank you for your generous introductions, and good morning, everyone in America. This is really an honor for me to be invited here to share my experiences with the Buncke Clinic, and thank you to Dr. Greg Buncke to invite me with these very nice and prestigious occasions for me to share what I have here with me. And good evening for everyone in Asia and Indonesians, and also with people in Europe. Good morning. So these two photos are one point that gave me the the interest to plan a visit to the Buncke Clinic back almost 2 decades ago. So then I managed to find this ID card, which is quite very nice to create back and to bring back the memory of me visiting a very prestigious unit in the Buncke Clinic in San Francisco. Besides that, the city is beautiful, so that, I didn't get a chance to write any paper during the visit because, every evening I travel around the city after the surgery with Dr. Greg Buncke and also the team in the Buncke Clinic. All right, so if I start sharing this picture, so basically planning the surgery with this disabling bilateral hands of children like this, it's going to be providing us with a good surgical planning. There are factors such as, how long would the surgery last for, and also after the scar release, how would be the resulting defect, and also the plan for the resurfacings, and also whether we deal with the potential involvement with the joint and also the tendons problem. But then, doing the surgery in this burn hand reconstructions could be very time consuming, especially with the suturing technique, and it's going to be exaggerating if you deal with the skin graft. and most of the time, resurfacing in children's hands would be with skin graft. So related to the point of my lecture for today, I got a chance to question myself whether we could abandon tourniquet. But then the subsequent questions may come: how would be the surgical field without tourniquet? And if you deal with the mitten hand like that, then you may consider that the surgery would be more complicated and longer, and you may question yourself whether you are able to create the clear operative field. So this is me this evening in Jakarta to share with you my experience with the secondary hand burn reconstructions without tourniquet, because this area of the surgery in hand is my personal interest. So my outline of this morning lecture in America is going to be the initiation to consider burn hand surgery without tourniquet, and I will share with you a little bit about pharmacokinetics and also other studies on the effectivity and safety of the tumescent solutions, which I share with you about my formula with 1 per ml tumescent solution. Some key factors to the success of performing non-tourniquet technique, and also the studies on the painless injection technique, as we got a nice sharing last week from Dr. Lalonde, and also about the wide awake technique, which I call the technique as fully awake hand surgery for hand burn reconstructions, and a little bit about the hand therapy and rehabilitations. Dealing with the surgery without tourniquet is still, questioned by many. So this is kind of like, invitations. I mean, an example for me to share with you that I got invitation some months ago from the Malaysian Orthopedic Associations, where practitioner hand surgeons in Malaysia invited me for one main reason, that she needed me to share the experience in the area of surgery without tourniquet, because it's very, what do you call, like, give like a situation which is quite resistant for her to promote the technique without tourniquet in the country, where mostly orthopedic surgeons are still reluctant. Although I could understand that, Dr. Lalon got very young surgeon from Malaysia who have a nice experience with non-tourniquet technique, which is going to be good for the group to have him as the champion in the country. So on the other hand, I would like also to share with you at the beginning of introducing the surgery without tourniquet for the hand, when I published the paper, reviews from blinded experts, like putting me into an isolated island being grilled with very tough questions. As you could see here, one reviewer questioned me with, quite the numbers of questions, which are all important, and then putting me into a very, what do you call, like, arguing situations where I have to defend what is the strength of the technique, because the paradigm of most of the reviewers, which I suspected is from the our counterparts in the orthopedic surgery, they have no idea about, surgery without tourniquet. And with the second reviewer, even much longer that I got review, and you cannot deny that, this is a fact that, even the third reviewer much longer again. So these are example of how people have been being resistive to the idea of doing surgery without tourniquet still till this current time. So then I challenged myself with a case of potentially easy to handle. So I started with a relatively isolated linear contracture. Although this may be still underestimated by many or even seen by others skeptically, and moreover, people make questions, why bother? Tourniquet would just do. Okay, just let me share the early experiences with this linear contracture, which is considered very minor. This is an example of a boy 6 years old with that linear contracture on those two digits. Then it's quite good for me to deal with the surgery, and I managed to do it without, tourniquet. But then regarding the formula, why would be 1 per ml tumescent solutions? Because people have the good experiences by the massive, extensive sharing by the giant Dr. Lalonde. So in this picture, I show you that he came to Jakarta in 2015, also sharing, quite, number of lectures. about this technique, where actually I got the chance for the first time joining his lecture in India back in 2009 in New Delhi. It was really like, very, very, very interesting to me, for me to know. But then, I did not really dare to start the surgery in the finger, in the hand of my patients with epinephrine, not only by abandoning tourniquet, but also with the epinephrine, where even until now, there are still big percentage across the globe where people are still against about using epinephrine in the fingers and in the hand. Hopefully that in the plastic surgery community, people are already been accepting the fact that epinephrine is very safe. So then I came into like, an idea, borrowing from the idea of liposuctions, where plastic surgeons are really handy with the procedures of liposuctions with the very low concentrations of epinephrine. So that's me started with the 1 per mil tumescent solutions. Basically, the epinephrine is in the 1 per million concentrations, and also with the lidocaine in 0.2%. The presentations of lidocaine in Indonesia is 2%, so I dilute 10 times, and the epinephrine is 1,000 times. So here are some publications that I managed to get success about, with the 1 per mil tumescent solutions. So before going on with the clinical surgery, I questioned myself about the safety with the solutions. So then the idea came when I got like, very strong, argumentations from very famous microsurgeons when I presented the initial work in Chile back 7 years ago, I guess. Then, he, as God in microsurgery, stated, there's no point for you to start with the tumescent injections for any perforators. It's going to be killing your flaps. So then we did the experimental study on the perforator flap, resembled by the tiny flap in the animal. So we did the ischemic insult to the groin flap in the Sprague Dolly rats, and then we managed to get a success. So in brief, that 100% of flap that has gone into ischemic insult, then we harvested a week later by injecting it with the 1 per mil tumescent solutions. There is no flap. There is no flap with a single partial necrosis, and there is of course no single necrosis of the flap. We measure the tissue oxygen, the transcutaneous oxygen pressure in the flap. If you look at the blue bar here, this represents the group with the 1 per mil tumescent injections before the injections, after the ischemic insult. The second group here, the second bar, which is tall here, is the second group with the injections only with normal saline. And the third one is without the injections. So after the injections of the tumescent solution, and we reharvested the flap, we got the outcome that all the flaps with the two groups actually decreases the pressure of the oxygen, and it's very significant in terms of the decrease. And the decrease in the group with the tumescent injections with the 1 per mil tumescent is much lower in terms of the when compared with the decrease of the oxygen pressure with the group with only normal saline injections. So this is of the representations of the flap, where on the left hand side is injected with 1 per mil tumescent solutions, while on the right hand side was injected with normal saline or with a control group without any injections. So it's a huge difference, a marked difference grossly. So we managed to analyze that yes, the flap suffer from hypoperfusions, and it comes from a combined role of the vasoconstrictive effect of the epinephrine, which is in very low concentrations, mixed with the role of the hydrostatic vasocompression because of the massive volume of the injections. In terms of the size of the flap, then the volume is considered as massive. Then the decrease is quite marked in significant indifference between the two groups in epinephrine and also with the normal saline injections group. We did also the study in the normal subject to find a similar hypothesis whether it exists in the finger of the patients. We injected here the pulp, and also we intended to find out the optimal time delay of the epinephrine. All right, so through that clinical study in the normal subject, we managed to see the significant difference in terms of significant difference in terms of the statistic difference with the decrease of the oxygen saturation.
Please turn your microphones off during the talk. Thank you.
And if we look into the oxygen saturations, was basically
Teddy, let me find whose microphone is on so I can turn that off. Here we go. Never mind. Let's see. Looks like it's okay now. Go ahead.
Okay, thank you. So then there is no sign of ischemia because the lowest of the oxygen saturation is just in the normal range. So then we prove that, you know, we did not see any chance for the fingers to suffer from ischemia. So yes, it suffered from hypoperfusions. Again, it proves the hypothesis that was taken of the proof in the animal study, that hydrostatic vasocompression is combining the effect of the hypoperfusions with the effect of vasoconstrictions of the epinephrine. We did also the study to the normal subject, and with the same study that we managed to get the optimal time delay, which is 14 minutes, which is a bit shorter. I mean, much shorter from what Dr. Lalonde got from his study, but then it's different in terms of the methodology. But then the outcome is basically still relevant clinically, because I would incise the skin or start the surgery 7 to 10 minutes after my last injections, and I would start from the earlier area that was injected. So here's of some clinical cases that given me the very convincing trial back 10 years ago. I remember that was this is the case that I did the surgery in January 2010. That, you know, it forced me not to be able to apply tourniquet, so that it forced me to start with nasal injection. Okay, so when you see the presentations of the incisions here, it's very clear and it's beautiful, because during the dissections you could clearly see all the cables without, you know, putting yourself in danger situations to jeopardize any important cables or structures. Now it's before the skin closure, and this is the outcome. And more complicated case with the kid. It was only 2 and 5 years old boy with this mirror foot that I injected 53 milliliters, and we managed to do the study smoothly without any problems with the bleeding, as well as all the recognitions of the important structures. I started also performing this surgery for burn hand cases with minor scarring in relatively considered as minor contracture in the digit of this 1-year-old boy. It's a flexion contracture. And if you could see the operative field, the outcome of the injection technique, it's very convincing. It's considered clear and very rare to put your gaussing procedures to clear up the blood. And this is during the hardware insertions. And this is by the end of the surgery before putting skin graft, and also this is a week after. So the next part of my sharing is about the effectiveness of pain control. So we did also the study to know the onset of action and also the duration of action of the 0.2% of lidocaine in the 1 per ml tumescent solution. So then the onset of action of that 0.2% of lidocaine is 5 times longer than the 2% of lidocaine. Interestingly, that the duration of actions take double of the length of the durations of 2% of lidocaine, which is only 100 minutes, and we got the length of the effect of lidocaine is almost 190 minutes. So the concept of slow injections is coincidentally in line with the common sense, like when we do the surgery on the upper eyelid. Mostly we do the surgery without sedation, so then the slow injection technique would put the patients in comfort. And I personally manage also to do the circumcisions for small boys with local anesthesia without, necessary to fight with the kids because of the personal approach, and also with a very slow technique of injections without creating pain. Only the first spoke, like what Dr. Lon shared with the concept of whole-in-one local anesthesia, but the focus now came to me with the syringe and needle combinations. Mostly people use 20 cc syringes or sometimes 10 cc syringes just to avoid reload the volume of the injection you may need to inject the tissue. But in my first try with this 20 milliliter syringe, it gave me very high pressure, so I didn't get a good strength enough to inject it. And I'm afraid that if I continue to practice it, then I may get the core vein or trigger finger. So we came into lab to study the pressure effect or the pressure of the mixture between syringe and the needle combinations. So you could see here from the graph that the initial pressure and also the maintenance pressure of 1 milliliter syringe or 1 cc syringe with 27 or 26 gauge needle, and also with a 30 gauge needle, is almost very small. It's almost nothing. Then when you compare it with 10 cc syringe, which is the highest, when you mix or when you pair the 10 cc syringe with 30 gauge needle, here with a pair of 26 and 27 gauge, with 20 milliliter syringe, still, even though still lower than 10 cc syringe, but the pressure of the maintenance pressure is much higher. It's very logical because of the high volume passing through a very small caliber or needle caliber. So a basic idea about analgesia by tumescent technique is about purely local anesthesia without block technique, and we use epinephrine with massive volume using diluted epinephrine and also lidocaine as the anesthetic agent in a very low concentrations. And the basic technique is subcutaneous injections. If you do really have the concern to inject intrascar or subperiosteally, then you may consider to use 3 milliliter or 5 milliliter syringe to give you greater what you call pressure to pierce into the very hard tissue. So we managed to publish some studies that we did the surgery without tourniquet in bone and joint, and also in the vascular malformation as well. So here is the first case of wide awake hand surgery or fully awake hand surgery in skin-related contracture, which is basically only linear contracture. So I'm kind of like chicken-hearted surgeon to start with a complicated surgery. So then with this linear contracture would be good for me to see how it works. Then it works well. With this basic Z-plasty technique, I injected 57 milliliter, which is, it's not in a normal practice of most doctors to inject this massive volume. And if you could see here how it looks when you do your incisions and also dissection, this is in the index and that one is in the middle finger, and you could see that the patient was quite calm and even looked very relaxed. And if you invite him to sing along with you, then you could sing songs together with him, or you could ask him to just sing song. All right, so this is the time when we managed to close the wound with all the suture, with suturing the flaps, and more than 2 hours of surgery were performed well. So here is a slide that I really would like to share it with you, that the surgery for the 2-digit here only with these 2 small gauze. And if you see the color, this is not saturated. These are not saturated by blood. it's mixed with the solution injections. If you see the background here, there is no really like, wet by blood. And I needed to inject for 7 minutes for that 57 milliliters, and I waited for 10 minutes, and that was the surgery for a bit 9 minutes more than one tourniquet session. And here, when we release the scars, the fibrous tissue underneath the skin, and the patient was just okay, relax, and smile. And we published the work with that early case on the fully awake hand surgery for hand burn contracture with a linear contracture. So now move forward with a less diffuse hand and digital problem. So with this isolated hypertrophic scar, I started to work with that 1 cc syringe. This is just to show you and how easy it inject when we inject the sub scar level, but then when we inject intra scar, you may need greater syringe, and maybe you could still pair it with smaller needle caliber. All right, still under general anesthesia, you could see how it's beautiful with the operative field without any bleeding that may obscure your operative field. This one with the incision, that one is with the dissection or excision of the scar. And so by the end of the procedures, I did not put flap as the palmar side was just normal. So we did also clinical study on surgery for burn scar, which people may consider that hypertrophic scar in burn has higher vascularity than normal scar. So then it may potentially give you significant blood loss or bleeding without tourniquet. And moreover, the meticulous procedures with or without skin graft would give you quite, relatively long duration of surgery. It may give you, more than one tourniquet sessions. So we subjectively assess the operative field clarity with classifications from totally bloodless, which is resembling the effect of tourniquet, and so with the other with minimal bleeding, meaning that you need only less frequent of gaussing. With the acceptable bleeding is more frequent. With the classification of bloody, you need to convert your surgery with tourniquet because you could not recognize, or you are not able to recognize all the important structures with your operative field clarity. So we assess also the scar thickness and density, which I took it from Vancouver scar scale. It's not really adopting the VSS, rather it's modified it. The thickness, it's not like the height from the Vancouver scar scale, because we need also to consider the scar under the normal surrounding skin. It's not about the height, but the total thickness of the scar. So we consider as thick if it is greater than 5 milliliters, or if it is less than 2 milliliters is considered as thin. Then in regards of density, I simplify the classifications. Label the skin as pliable if you are really facing a supple skin which is very mobile and soft, with a solid and inflexible skin with that scar, you label it as a high density scar. So the longest duration in the series was 450 minutes, very long. So consider, if you apply tourniquet, then you need to apply 3 sessions of tourniquet. Only 2 patients with surgery less than 2 hours. So one of the important data that I would like to share it with you, that its likelihood ratio with the thickness, when you face a thick scar, then it's likely for you to less likely for you to have a bloodless operative field. And so with the density, it's much higher, 17 times with the what do you call, like the worst of the pliability, density, the scar density. So you will end up with difficulties because of the less clarity of surgical field. So from that study, we could create summary that one terminal tumescent technique is effective to facilitate the surgery for hand burn deformity because it creates relatively clear operative field without tourniquet. Although scar thickness and density play their roles, but then it's considered safe and effective in creating clear operative field because I did not need to convert any surgery into tourniquet. So for the past decade, and it's moving on in the You are 11 that I've never convert the surgery into tourniquet. So this is another case with full awakening of hand surgery. That is the injections where I needed to re-upload with that 1 milliliter syringe. Patient's a bit nervous, curious, but it's quite calm. And the beauty of this injection is that it gives you like swelling effect under the scar. So you could, identify all superficial vein here in the dorsum. So then you could preserve without any, injury to even superficial vein system in the dorsum of the hand. It gives you quite clear. So another case with, considered as relatively diffuse contracture when putting hardware on the calm patients. So here we call the patients and he respond to the chats. And another case here with more diffuse contracture, consider how much the amount of injections, 81 cc in this one hand. And so an example with diffuse contracture where the patient is just calm. Yes. All right. Okay. So at the end of the day, that long surgery was managed to do without any, conversion into tourniquet. This is another sharing when you do need to harvest a skin graft. This is an example where you harvest quite large area, and I injected on 95 cc here. Then let's just wait for a few seconds to see how it looks on table. Just a few seconds more. Yep. It's beautiful. Yeah, you could see it's bloodless. And so with the full thickness skin graft, you see that, different color here after the injections. It's quite large amount of tissue to be injected in that, large area of full thickness skin graft. So then dealing with, hand burn, you most likely to deal with web contractures because it's quite most common problem along with flexion contracture and also with syndactyly. First web is one of the, not one, I mean the most important area for you to deal with. And so with the web creations, I'm fond of the dorsal pentagonal, the islanded flap like this. It's really kind like perforator flaps where you rely on the perforators in the web and you actually manage to create a nice sloping web with those dorsal pentagonal islanded flap even for burn scar. Of course, dealing with hand burn, you may, quite frequent see the joint balancing problem. The problem comes not only with the scars in the skin, on the skin, but also with the dysmogenic contracture problem related to the problems in the tendons and also the fibrous structures, and also potentially with the arthrogenic problems. So that imbalance of the hand burn creates, quite, various deformity, including clawing, and so with the loss of the intrinsic muscle function. Of course, this is quite common with joint distension by the scar, and this is an example of the problem that may involve also with the joint, with the arthrosis like that. So if you do not really get the privilege to do the arthroplasty, then you may end up with arthrodesis. An example where you could use the reverse homodigital island flap to cover the raw surface that is created here in the dorsum of the distal interphalangeal joint. So an example with the clawing of the MP joint, so we could do the volar plate tightening or with the advancement flap from the volar plate, and also with the reconstructions of the volar plate with tendon graft if you do not see the structures of the volar plate that comes in an intact conditions. With Buncke deformity, there are some of the armamentarium that you could perform with the lateral band centralizations or with the extensor terminal lengthening. Then an example of the ring finger after corrections of the Buncke here. If you see, it's quite a satisfying outcome, although the middle finger needs still further correction. So another example with the fully awake hand surgery for Buncke in the index and also the swan neck deformity in the little finger. So what I did here as an example for the index, after the zigzag skin contracture release, then I did also the central slip reconstruction with the palmaris longus graft. And for the swan neck of the little finger here, not only by releasing the skin contracture, but also with boilerplate tightening. Although in this case, I did not do the extensor shortening. So this is the outcome. The little finger was previously hyperextended, and the index was previously flexed in the Buncke deformity. And so you could elaborate your technique with swan neck deformity corrections using the one arm of the FDS to create the flexions positions of the proximal interphalangeal joint, an example of multi-digital problem with the swan neck. So it's good to see that it functioned well rather than in the swan neck, which is quite not really functioning with the daily living activities of the patients. Here I would like to share with you some complication that may come up with tumescent injections. One of the complication that I consider as quite minor is about blistering. It may pop up in the secondary burn surgery or sometimes with a congenital case because it's too much pressure, too much volume. It gives a higher pressure than the tissue could cooperate or could cope with, and some temporary bluish, including also with a trauma case. I'll give you an example, which is quite good to give you what sort of idea with this problem. So this is a quite difficult case with a congenital problem here with a syndactyly, where I did not really predict that the outcome will give you scissoring effect like this, so that it comes from the bone development that's still connected to each other, although it's not really united. But this scissoring problems is really bothering me. So we did the release, the corrections of the 2 digit to be in a strengthened positions. So right on table, if you see here, the ring finger looks pale and the distal part look bluish, just on table. So I'm sorry that I am obscured by the thumbnail. Hopefully that you could see the video. This is 6 hours. I did nothing, just observe. And for the first 6 hours when I saw this, so I just asked my resident to loosen the bandage without other interventions. Just observe. Here's the 12 hours. And you could see it's not really ischemia, it's by the backflow, meaning that the constrictions by the backflow. This is 18 hours, a bit better. But then, after a day of 24 hours, we get the blister here. So just break the blister and do nothing. Just put ointment after the blister breaking. This is 36 hours, and today's I just discharged the patients. And you see here, day 5 after. So for 11 years onward, I've never lost any single digit with this tumescent injection. Just want to share with you again the idea to understand what we made a study earlier that I presented earlier, that here in the distal part it looks bluish, and this area that was injected is pale loop, and this is just by the venous congestion because of the massive volume in the proximal part, and it does not really create ischemic digit. And so with the different patients, similar presentations here, bluish at the distal part. And so that one, almost 70 cc injected into the hand. And if you see, it's just, it's just by the venous congestions. Hyperperfuse, yes, but not ischemic. All right, a bit about the hand therapy. So of course, just as a reminder for you that dealing with hand burn, then we need to be ready with the pressure garment. And so with some modality, this is just an example to prevent the Prasetyono deformity, Malay or swan neck, and also preserving the first web and preventing the flexion contracture, safe positions with the lumbrical plus, and also with the dynamic flexion and also extension splint. So I myself personally rely on the self-exercise by the patient rather than asking the patient to come into the rehabilitation clinic to meet with the hand therapist, just to meet for half an hour or 1 hour sessions, let's say twice a week or 3 times a week. No. So very aggressive self-exercise is necessary to the patients. I mean, done by the patient himself or herself. In terms of multi-digital contracture of bilateral hand, the principal difference between children and adults that in children we need to put the hand in sandwich splinting because of the less cooperative children relatively, and also in adult we do really need caregiver or family members to assist with the exercise. An example from the case that I've shown you from at the previous slide with a mitten hand here. So night splint ready at 1 month. Basically, it's like creating a good splinting technique and allowing the patient to start using the hand. Another example here with the case that you've already seen it from the previous slide. So during the daytime, after 3 weeks, as the common rule in the practice of hand surgery, just put the pressure garment, and at night I needed my therapist to apply the sandwich splinting. So here's an example of the outcome 1 year after the surgery. Bilateral contracture, which is quite acceptable and nice, is active boy. So in terms of bilateral hand cripple, the target of reconstructions need to be set lower when you face major drawback of lacking support from relatives, because the patient would not help himself when the other hand, the contralateral hand, is also in crippling. I mean, it's also crippled. So set the target based on the basic prehension of the hand, starting with the idea to create simple handling, precision grip, and if it is possible to involve with the ulnar raise to allow the patients to be able to perform digital palmar holding, and of course, ideally to do complex manipulations. So the key is actually in the master of the hand, which is, yeah, everybody knows, the thumb, and also the metacarpal joint that should be well in functions to allow the basic prehension. Example of simple handling, example of precision grip, which is quite nice to see that the patient is actually able to do that, although being disabled with his or her bilateral hands. All right, so another example with the digital palmar holding to involve the ulnar raise to be in good functions, or sorry, in relatively functioning hand, right? And so with the complex manipulations, although the patients experience several joints to be in orthodesis, like the previous patients, this one, you needed to concern all the joint problems with these presentations, and also the orthodesis, again, without tourniquet, and also fully awake. And you could manage to see the outcome with this complex manipulation as you have seen it from the previous slide with these patients, right? So at some point, the orthodesis might be the only choice for you, rather than dealing with all other the skin surface and also the tendons, because you do not expect, if you do not really provide the patient with arthroplasty, then if you see these patients, I'm not thinking like I'm going to be a hero to be able to provide a good outcome with this patient. But at least you could see, some points as the target you have set to be achieved. And with this case, actually, it's quite satisfying. If you see again, some videos is taken from the previous video, right? It's quite skillful, although it's crippling hand, Yeah, I consider that, the patient got still disabling hand, but he's kind of like, quite satisfied and did not really want to go for further interventions. And he did get back to his work, although with some adjustment. All right. For the glory of the patients, I would like to share it with you that, rehabilitations need to be accompanied with return to work programs. So this return to work program are at the utmost. I think you would be very happy to see the patients back into work, based on the program that is, in collaboration with the company where he works, to set the programs and put them into training rather than, merely, fulfilling his jobs or her jobs. So this patient started with this, deformities, very difficult for me, but then, I'm happy to see that he's back into his, her activities. And another patient, which was quite, satisfying, achieving full normal function from that point into this point, bilateral hand. Sorry to just to show you the right hand. Very skillful, able also to do all the delicate procedures with the complex procedures. Another example from this starting point, you see that previously he was started with this problem, and then I still did not really get, based on the first surgery with this tourniquet and also with the little finger. But as you see here, managed to set him back into, normal work. Okay, well, I think, I would like to end the sessions with my own feeling. I'm longing to travel again because, in the normal before pandemic, in the normal situation, normal conditions, so I travel at least 10 times in a year, and hopefully that I got the chance to visit the Buncke clinic again, and hopefully in the future could create collaboration, at least with some research project, if Dr. Buncke and the great team would allow me. But then it would be good for me also to invite the great people in the Buncke clinic to visit Indonesia. Indonesia is not only just Bali. This is an example of a part of East Kalimantan with the Derawan. It is quite famous. Again, the Rawan at East Kalimantan, and this is just next to Bali, not Bali. This is the Lombok Island with the Gili Trawangan, small islands, beautiful places to visit. And the Raja Ampat at Papua is considered as the most beautiful diving site. So then, with that, I would like to end my sharing this morning and this evening in Jakarta by acknowledging the staff members in our department. He is the caricature of the chief member, oncologic surgeon, and also I would like to thank my collaborators with research. Thank you very much, Boba, and the audience. Thank you very much.
Thank you, Teddy. Fantastic talk and really great cases. We were chatting while you were resetting your system about the applicability of wide awake local anesthetic surgery in cases where there's a lot of scarring involved. And clearly you've shown that that's definitely possible. A question about injecting into and around scar. Do you have any difficulty injecting the anesthetic into areas that are very, very scarred, and even with a small needle or small syringe rather, is that easy?
Oh yes, so then, just to encourage people to start with, I would encourage you to inject in the subscar. So make sure that you are not entering, blood vessel. Just start with a subscar with that, 1 cc syringe if you consider to do the fully awake hand surgery or wide awake hand surgery.
Mm-hmm.
And then after numbing the area in the subscar, so you may start using the greater needle with 3 cc or 5 cc intrascar if you really would like to see the scar. When you do really want to excise it, it's going to be bloodless. Maybe in the future I would share with you that I use also the scar skin. So imagine that if I slicing the scar skin from the scar to be used it again, to be used, so I use it again, reuse it again. So I needed to do the excisions intrascar. So meaning that, I needed also to inject intrascar. It's pretty hard, but once you manage to push the tissue with your big syringe, then I think you could just practice and you see that it's going to be okay.
Mm-hmm. Now, any role for steroid injection around the significant scarred areas, or do you worry about wound healing potentially if you use steroids?
Sorry, say it again. What, synovial?
Any role for steroid injections
Okay.
into the scar as well, or do you worry about maybe wound healing problems if you inject steroids?
Yes, yes. I do not rely on corticosteroid at all because I'm kind of like, a believer with that corticosteroid to reduce the first phase with the inflammatory phase. So this is not in my practice,
Mhm.
corticosteroids.
Great. Now, Greg Buncke was commenting on when the epinephrine wears off, sometimes there could be bleeding that you may not have seen before. Any tips or tricks with regards to minimizing the incidence of hematomas after the adrenaline wears off?
Wow, great questions. Dr. Buncke, I just want to convince you that, I did not experience any single hematoma with these epinephrine injections. So, so what another beauty is that, the pain, although I haven't come into a real clinical study to see how the post-operative pain, because it's still mixed with the prescriptions of analgesics because of the ethical concern. But mostly the patients just spend for a night if you do your general anesthesia. But for local anesthesia, if you start the surgery in the morning and you finish in the afternoon, quite early in the afternoon, then you can just set the patient home. But
Hmm.
in our series where we got the patients with public insurance, we needed to put the patients for a night and then we send the patients back home. And when they come into the follow-up, we did not really see the hematoma.
Hmm.
So it's quite good. But then I would like to share with you with some of the congenital cases. Then the hematoma may give you like minor problem to your skin graft if you put skin graft on, let's say, with a difficult case of upper hand, for example, but not with the burn hand.
Got it. Now, with regards to the web spaces, do you have any special tips or tricks to prevent web creep when you have these little syndactyles from scar formation?
Yes, yes, this is the problem for everyone.
Yeah.
Of course, yeah, right. So just soft splinting that we are not really what do you call like got the chance to have a fancy relationship with the hand therapists and the department that they could provide the proper splinting. So what I advise the patient is just to use the pressure garment for adult patients, but then before putting the pressure garment, put a soft
Hmm.
soft splinting with gauze or with linen, just to push it proximally backward. And so with the children, we advise the parents when they got into beds and during the sleeping, and they put a pressuring soft splint in the web. The
Got it.
difficulties with web creeping is with the congenital anomaly, especially with the upper hand.
Yeah, no, definitely. Um, and the last question, you mentioned the use of local anesthetic and epinephrine in elevation of perforator flaps. Are you doing much flap elevation wide awake with patients with just local anesthetic and epinephrine?
Yes, if I got a chance, so I would love to do it in local anesthesia. But then, quite numbers at the latest years, we got more into children with
Hmm.
the necessity of flap surgery, perforator flap. You just put the injections just to allow you having a clear operative field. But if the patients really, give you agreement to do the surgery on wide awake, yeah, sure, we could perform the surgery wide awake. Like, for example, with the skip flap, it's going to be fantastic for you to put your patients awake because we manage also to do the what do you call the spaghetti race, which also come with the nerve and also the arterial problem. So basically, you do your micro anastomosis with the ulnar of or radial artery and also with the nerve in fully awake after
Mm,
5 hours or 6 hours, repairing all those cables. Yeah, we did that.
great. Excellent. Well, Teddy, thank you so much for this very interesting talk. I think it inspires all of us to try to push the envelope more with wide awake, local anesthetic surgery, and also not be afraid of using epinephrine in the hand, which you've shown is pretty safe. Also, I think we all would love to visit Indonesia as well. It's a very beautiful place that I've never been to, so I'd love to at some point visit you there as well.
Yes, please make sure that I will, come to you and also to Dr. Buncke.
We'd love to have you here as well. So it'd be great to once the travels resume to see you here in person.
Thank you very much.
Great. Thank you, Teddy. Have a great night. Thanks again for your talk.
Thank you. Enjoy the day.
Thanks. Bye-bye.
Bye.